Yes, sir. We are live. So we'll just wait for 2 minutes, sir. Some people are just joining in, and then I'll start the session.
Sure.
Good evening, everyone. The stream is live. Thank you all for joining exactly on time. I'm just waiting for 5 more minutes for more people to join, and then we will start the lecture by Dr. Sippy. All right, sir. Okay, Sippy, sir. I think we can start.
Okay.
Yeah. I'll just give a brief introduction, sir, and then we'll go ahead. Good evening, everyone. I'm Dr. Rajkumar. I represent the Society for Healthcare Simulation, India, and I will be moderating the session by Dr. Sippy. This session is about achieving financial self-sustainability in the field of high-fidelity simulation. As you all are aware, high-fidelity simulation is something which is not a joke. It's a huge investment by the management. And just using the high-fidelity mannequin for your PG's training and for your undergraduate training is likely not going to be enough. So how do you actually monetize your investment? How do you actually show a return of investment from your mannequin is what this lecture is about. We have with us an expert in this field, Dr. Nitin Sethi. He has 11 years of progressive and versatile professional experience in healthcare, academia management, simulation-based education, university administration, international collaborations. He has multifaceted leadership roles, exceptional strategic initiatives by fostering collaborations and changing management. He's built proficiency in process and quality improvements, leading to operational financial excellence in healthcare education. And he's also an education policy researcher. He is one of the first persons to bring in a profitable healthcare simulation model into India. And he's been working closely with the Mayo Clinic as well, bringing in Mayo certified instructors to the Indian base of simulation education. And Sippy sir, I think that should be more than very less about what I know about you and what you bring to the table. So let the speakers find out for themselves. Let the audience find out for themselves. Please, sir, over to you.
Thank you, Raj, for this introduction. And good evening, everyone. Before we start the session, I'd like to have a small disclaimer that if there are any clinicians who are not into the financial world or who are not into the administrative language, you might find this kind of slightly off. So no worries, we can have the discussion, one-on-one discussion later on. My credentials are with Dr. Raj. So without wasting further time, I'll start the session. So hope the screen is clear.
Yes, sir, it's perfect, sir. Please go ahead. Sir, before you start, just a small disclaimer, everyone. If you have any questions, please type it in the YouTube live chat. I will be presenting the questions from the CP at the end of the lecture. We do not want to interrupt this flow. And there will be a feedback form given at the end of the lecture. So you can type in your feedback and you will be given a certificate for attending this lecture. Thank you.
Thank you. So this is today's topic, as Dr. Raj mentioned. But before going on to the topic, I'd like to take a minute to explain about us. Is our honorable founder, Dr. D.Y. Patil, and one of his famous statements, which I like to recite every time, is ego is death of life and death of ego is real life. So a legend by himself. Today we have 5 universities, 10 campuses, more than 10,000 staff. The next legend is Dr. Vijay Patil sir, who is the president of the D.Y. Patil Group. He's a he's a great visionary. We have grown under his umbrella, and it's his vision that the DYP Group is on its cloud nine. We at D.Y. Patil University, Navi Mumbai, have 3 areas of interest: education, healthcare, and sports. Education, we cover into 4 areas: health science, technology based, independent streams, and schoolings. Hospital, needless to mention, one of the largest in the area, and all the credentials are mentioned. The most beautiful stadium, needless to mention the events that are happening here. Um, just a small brief. Now, the topics that we'll be covering today. This is a small roadmap. We'll first see what are the 7 success model in simulation. What are some economic evaluations? What are some global return on investment frameworks in simulation? And what has been our journey at D.Y. Patil University? So to start with, the 7S model for the success of simulation. As it is well described, the 7S starts with science, that is the technology that you're using, the staff, the manpower, the clinical world, the technical people, the operational people, the space, the infrastructure, systems, supplies, support, and the last and the important is sustainability. Now, why do we have sustainability as an important aspect? I believe whether it's a private institution or a government institution, if there is sustainability, there is growth. And successful simulation program is not a peak to achieve. It's a success. So after sustainability, if you prove sustainability, we will have growth. So sustainability is not the end. It is not the Mount Everest to be climbed down. It is a part of the circle. The second area is what is economic evaluation? Now, we might be moving towards slightly technical areas. So let us say we are, as a general rule, investing into any product or any service or a group of product and service. So the first comparison that we do is what is the benefit or an effects or what is the investment is to benefit analysis. Now, if you are able to do that, and if you are able to document a meaningful threshold, then we should be doing a cost minimization analysis. If not, we should be doing a simple cost analysis. Now, if you are not able to document a threshold to the effects, can we analyze whether these effects can be monetized? If yes, a cost benefit analysis has to be done. If no, then the measure of this benefit on the usefulness, whether satisfaction, how do you measure this? Then we should be doing cost utility analysis, if not cost effective analysis. Now, lot of analysis words we can see here. Just to summarize that which type of analysis should we proceed is the foundation stone for achieving sustainability in simulation. Whether we do cost analysis, cost minimization analysis, the cost benefit analysis, cost effective analysis, or cost utility analysis. Ideally, all these 5 analysis are itself a presentation in the financial world. But we will not go into the depth. This is sufficient for understanding that which type of economic evaluation should we be choosing on. Now let's take an example of a medical university which is based in a tier 1 city. Now in India, if you see, there are medical universities, standalone medical colleges, location matters, whether it's a deemed university, a state private university, or a standalone medical college. But let's not take these areas into picture. Of course, these areas should be considered, but for our discussion for today, we'll exempt those. So let us say a medical university invests as a phase 1 in the range of 4 to 6 crores. Now, if it invests in high fidelity patient simulation, ultrasound simulation, surgical simulation, or a mix of all three, it's a very difficult decision to be taken in today's time. The clinicians will push for their specializations simulation. Let us say an orthopedic guy might push for orthopedic simulation. Anesthesia guy might push for anesthesia simulation. But the management or the decision maker or the decision contributor have to analyze where are we starting from and what is the vision of the center that it should achieve after 5 years or 10 years. According to our analysis, according to our experience, the two areas that we state are that if a medical university invests around 4 to 6 crores as a part of phase 1, it should ideally invest into high fidelity patient simulation. Please mind, we are not covering anything on the task trainers because we feel that task trainers are an essential part and that should not affect or impact the decision of the sustainability. That's a part, it's a regular process. Today we see 250, 300 bed hospitals buying task trainers of 30, 40, 50 lakh rupees. So let's keep task trainers out of this whole discussion. So the investment is to benefit ratio is very high. Thus, if the ratio of investment is to benefit is very high, the return on investment or the ROI period that we say can be easily achieved in 2.5 to 3 years. Now, when we say ROI period, it of course depends what is the team size. If you see today, many of the high fidelity simulation centers in India are running, but whether they are effectively running, whether they are running efficiently is a big question. Now, to achieve a ROI period of 2.5 to 3 years, you need to have 3 teams into place. That is, first is the clinical excellence team, which will be composing of your simulation trained faculties. Somebody might be a good clinician, but the turnaround time to become a simulation faculty is minimum 6 months to 1 year. Now, during this period, whether your center should be a low performer or a high performer. So, achieving clinical excellence or clinical simulation excellence right from the start has to be a very important strategic move. The second part to achieve this ROI is a technical excellence. You should have a team of dedicated, please mind, dedicated, not shared resources for biomedical and simulation operations. Now we have seen in the western part of the world that nursing people, biomedical people, they are itself handling the operations of a simulation center. It's good. There's no problem in that. But if you have a dedicated person with an experience of operations management, let us say hospital management, then he or she, whoever is the operational excellence guy, will be responsible only to ensure that the operations of the simulation center is maximized to its potential. Moving on, let us say the same university invests as a phase 2 in 3 to 5 crores in ultrasound simulation. Now in ultrasound, you have various types of ultrasound. There's diagnostic ultrasound, interventional ultrasound, and so on and so on. But still, we have seen and we have proved that the ROI period is 1.5 to 2 years. The most fascinating and the most handsome part of simulation is the surgical simulation, which is a attractiveness for all the clinicians. And no doubt about it, it's one of the fantastic simulations. But it has a low investment to benefit ratio. So the ROI period is very, very high. We have seen many, or I would say some of the few standalone centers into surgical simulation who even after a period of 8 years could not achieve the ROI period. So investment into surgical simulation is essential, but which one and when is a high risk question that has to be decided strategically. Let's see another example of a tertiary care hospital. Now in India, you don't witness tertiary care hospital investing into a high fidelity patient simulation or ultrasound or surgical simulation, barring countable examples. But still, the ideology or the methodology for a good ROI remains the same. That is patient simulation followed by ultrasound followed by surgical. Now, the third part of today's presentation is the return on investment. Now, there are three different models available and developed by our Western counterparts. The first is the Kirkpatrick's Phillips model. Now, please mind, there is not a single model available which is error proof or which would be the best. We'll come to this discussion a few minutes later. Let us focus on the Kirkpatrick Phillips model. Now, this model is very much essential, or it should be advisable when you have to analyze the ROI period for a certain program. So you will do some evaluation planning, you will do some data collection followed by data analysis. You will capture the cost of the program. You will identify the intangible, tangible benefits, and then you will be able to identify. So let us say we are developing a 2D echo program for a 2-day or a 3-day period for, let us say, 10 cities in India. So then this kind of the Kirkpatrick Phillips model is ideal for designing the ROI framework for a program. But let us see another model that is available known as the Frost and Sullivan model. Now this determines the payback period of each simulator. How? Because it decides into 4 contributing factors. That is the cost of the simulator. What are the financial benefits of the simulator? What are the non-financial benefits? And after the training, what are the benefits that are passed on to the patients? All these 4 factors taken into consideration, you can decide the payback period for each simulator. This is for each simulator, not for a center, not for a program. Now, the third model, the third model is the value measurement methodology, or known as the VMM. As the word suggests, it measures the value. So basically, it categorizes values into 5 different types. First is the direct value. That means, what is the benefit of simulation in training the particular educational experience or type of trainers or users? The second is the social value. What effect does it do to the public health of the community? Does it improvise the general health? The third is the operational value. Now, when you have good public health infrastructure, when you have good doctors using simulation, does it decrease the average length of stay of a hospital? So let us say average length of stay is known as the ALOS. If it decreases or impacts the average length of stay in the hospital for a patient, the operational value has to be taken into consideration. The fourth value is the strategic value. And fifth, that is the financial value, that how much it increases the revenue or does it reduces any other factor. Now, we have seen all these 3 models. Now, Sorry, I think there is a lag on the presentation. Yeah. So now let us summarize all these three presentations, all these three models. Now each one have their own uniqueness and each one has their own gaps, which is well depicted here. So like the Frost and Sullivan model emphasizes on the payback period of the simulator. It does not specify anything about the type of training, the period of the training. It does not consider. So that's the gap. So, like, and the Kirkpatrick Phillips model, it does not consider any non-performance related benefits. So ultimately, which one is the best? There is nothing called the best model. We have to decide our own model. We have to come up with the pros and cons. And one of the simple methodology that we have been using in DY is this. We first determine the total project cost. So the total cost you can divide in two parts, a project cost and operational cost. The project cost will start from the initial analysis. Remember the economic evaluation slide, the implementation, what will be the overheads, what will be the project, is there any acquisition involved, acquisition of the space, those all will come into the project cost. The second part of the total cost will come as operational cost. The materials, the equipment, simulation equipment, furniture, maintenance, labor. So this should be the total cost. Generally, we see in India, we say that we have put up a 5 crore lab or a 10 crore lab. That means we have purchased simulation equipment of 5 crore or 10 crore. That is wrong. All these costs have to be added. Now, we have analyzed and bifurcated all the key parameters into quantitative data and a qualitative data. So quantitative data, we have taken the financial value, the impact of social values, operational value, strategic value, and direct value. While the qualitative data, we have taken the other areas. Now, those qualitative and quantitative measures, we have transformed into tangible and intangible values. Ultimately, coming to one of the best formulas, the return on investment can be calculated by all these net benefits, all the values that we have taken up, divided by the total cost of simulator into 100. So indirectly, if we determine the ROI, we are also determining a target for the center head or the center director to achieve the investment in this period. So let us say a management has taken a decision to invest 5 crores or 10 crores. First, if the ROI is determined, it should be taken into consideration that the ROI has to be achieved in 3 to 5 years or whatever the number comes. So this is about a ROI framework. Now, what have we done in DY? So I just summarized. These are the various milestones. We started in 2013. We had different milestones. We associated with Mayo Clinic USA, and we have done a lot of online high fidelity simulations. We started in 2013. Sorry, there's a lot of jumps in the slides. This we were in 2013, the same space that you see here. From here, we're here today. This is the whole 8,000 square feet simulation center in Navi Mumbai and our sister concern, the 10,000 square feet at the Kolhapur. To summarize, what have we done as a simple number of workshops with the number of beneficiary? Remember, we said about the beneficiary is to investment ratio. So investment, we know what we have done. But to identify the number of beneficiaries, this can be one of the charts that can be used. So as you can see, in the last academic year, 2021, we had almost more than 10,000 beneficiaries. And all of these, all of the workshops, we have a rule in the center that all of the workshops documentation is done through the simulation center management system, that is the learning space. So we have a management control, we have everything recorded on the simulation center management system. How do you do external tie-ups? This is just, you get tied with various medical associations. You have to do a lot of demonstrations, MOUs, discussions, scenarios, and then you do one project. Now, if you see what developing a simulation center is one project, but making it self-sustainable is a long journey. So this shows what could be the milestones in achieving it. So after development and building of a simulation center, which is the first ground stone, we will have to have various dry runs. We should have your own good marketing materials, brochures, workshop videos. So at DY, we have our own YouTube playlist. We have more than 42 videos which have been shot, edited by our own IT team of the university. We have more than 42 SOPs. And when we say SOPs, that means right from how do you start a simulator, how do you run a program, how do you achieve parallel excellence, various associations, and then you become a self-sustainable center. So this you cannot do it alone. A center head or a director of a simulation lab can never do it alone. He needs teams. He needs a clinical excellence team, a technical excellence, a operational excellence, a marketing excellence. He needs these teams. And then the leadership has to support. Just before concluding, a small video for all of you. So we covered in short the economic evaluation, the ROI framework, our journey, and ultimately it leads to a question that what do we want to do? So that's all from my side.
Thank you so much, sir. Sir, if you have any questions, please type it in the chat box. I will take it up to sir. Sir, I have a few questions which I am facing at, as working at a simulation center, things that always will come up, issues that pop up. One such thing is when you're part of a medical college simulation center, not a standalone simulation center per se, how do you incentivize your existing faculty to come and teach at the simulation center?
Right. So fantastic area. That starts from the point that let us say we need to have dedicated 10 simulation faculties with us. So right when we're executing the train the trainer session, right, whether it's debriefing sessions or the software or whatever types of training we are doing it. Some people take it with the company people, somebody tie up with other universities like we did with Mayo Clinic. So there is a kind of understanding and arrangement with your faculties that let us say if we are training XYZ faculties, there is a cost involved on the training. Now, once developed, that faculty should dedicate a certain amount of time per month. So let us say he or she decides to dedicate not more than, let us say, 2 days or 3 days a month, which is beyond his academic duties. Now, for that mind, that faculty to develop good clinical content into simulation content. Let us say he has seen, let us say he's an intensivist or an EMED guy. He has seen a good case in casualty or ICU. He can recreate that case into a high fidelity simulation center. So if for doing that, he needs to be incentivized. Incentivized can be a per day basis or a per workshop basis or a per half day basis. It all depends on what the management vision is, but it should be incentivized, and that what leads to long-term retention of the faculties. Otherwise, the center trains people, faculties work for 2 or 3 years, and then they shift to another side. So touch wood, all the faculties trained by us till date are still with us.
Yes, sir. So there's a question in the group. Thank you for sharing your experience. Can you suggest few milestones which should be focused during phase 1?
Which should be?
Focused during phase 1.
Okay. So the first milestone is that what are we trying to achieve in the phase 1? To achieve a ROI period of 2.5 to 3 years, the first thing is development of faculties, development of technical team, and development of operational team, which should take not more than 6 to 8 months. So ideally, if you have a good 3 teams into picture, followed by the marketing team. So you have 4 teams into picture. Your marketing team can be a shared resource with a university or with any other business of the management. And when you have these 4 teams into picture, which should be ideally between 6 to 8 months of your inauguration of your center, that should be the first milestone.
Right, sir. Right. There's one more question, sir. Is there any program for sim lab technicians? This is a question we get a lot too.
Yes. So we have developed 2 in-house programs for SimLab technicians. So basically, a SimLab technician, uh, our concept is slightly different. In the Western world, if you see, they cover, I would say, 60-70% of the technical and 20 to 30% of operations part of a simulation center, which is great, no doubt about it. But if you see the Indian mind, the typical biomedical engineers that graduate or who are into biomedical electronics, expecting those minds to do an operational excellence is more than what is required. So what we have developed a program internally. We have a senior manager, biomedical services, who is dedicatedly and trained in Germany, Mr. Ninad Kubel. He has developed a program with the technical head of CAE, and we have come up into a program wherein the first month involves understanding of working of a simulation center. So we have the program, let us say if I have to conceptualize, let us say we have to develop a cath lab technician or a CT MRI technician. First, he or she should understand what the process is doing. So we first induct first month into the center, into the working of the simulation center, and then the operational issues, the troubleshooting, those are described. There is a proper booklet of SOP of how to start a simulator, how to shut down, how to report a problem, and everything we do it via the simulation center management system. So we know the progress of the development of the learning curve of the staff also. So there is a simulation technician program. It is in-house only right now. We are soon to launch as an external program, but not yet launched.
Okay, sir. So one last question, sir. This is from Dr. Tilaga from Apollo Chennai. She's heading the simulation center there. Maybe you're familiar with her as well. She's from AIMS Delhi. So this question is, how do I calculate return of investment for intangible returns, such as improvement of patient safety or quality?
Right. So
if we know that the patient care is improved, yeah, but we don't know how we can calculate it. So yeah.
Right. So if you see the one of the ROI framework models, it very much mentions what is the so let us say you have trained a particular group of consultants or students who used to perform a particular procedure, XYZ procedure, in a particular manner. Post simulation, the procedure performance has been improvised. Now, how do you document this? Is using the pre-test and the post-test or the feedback mechanism or various simulation mechanisms that the faculty develops. But That is his in simulation environment. But what does he do when he goes to the hospital side? And that's what he used to do before that, before the program, before doing your simulation program. And what is he doing post the program? And that's how you calculate the benefit on the patient. So actually, what I have not covered in depth. If required, I'll share the details later on. There's a particular way, there's a particular methodology by calculating not only the intangible benefits, but also the impact of patient improvement in by use of simulation.
Right, sir. Yes, sir. I think I will get you two in touch, so probably you can talk about this. And for people who are interested, I will be sharing the feedback form right now in the chat box. You can type the feedback and get your certificate. And Dr. TCP, sir, thank you as always for always being supportive of SHS and Assembly
Thank you,
Cons.
Dr. Rajkumar, and the management team of GSL Smart Lab, GSL, and Society for Simulation Healthcare.
Thank you, sir. And just an announcement, the next webinar is also from the team at DY Partner. This time it's going to be an expert in simulation, in designing and planning a simulation center. So it's coming from an architect, not just a doctor now. An architect who will guide us through what is essentially required for planning and designing a simulation center. A lot of you are coming from colleges which are just now building up their skill labs, going through phase 1. What should you think about in phase 2 and phase 3? I think he'll be the right person to talk about it. And that will be in the next 15 days or so. I'm looking forward to having you all there. Please submit your feedback and you will be getting your certificate as well. Thank you so much for joining us today.
Thank you. Thank you, Dr. Raj. Thank you, everybody.